Welcome everyone to our webinar today, Practical Solutions for Delivering LSVT LOUD or LSVT BIG per protocol. And we know this is a popular topic, and we hope that this webinar provides you with some nuggets of information that might be helpful to you, whether you're a clinician who's considering getting LSVT certified or even a clinician who already is certified and is looking to learn a little bit more. So today the presenters will be myself. My name is Laura Gousset. I'm a physical therapist and one of the LSVT BIG training and certification faculty and chief clinical officer of LSVT BIG. And I'm joined by my colleague, Beth Peterson, a speech language pathologist and also one of our LSVT LOUD training and certification faculty. Both Beth and myself have many years of experience providing LSVT LOUD and LSVT BIG, and I won't read through our bios here, but they are here for your reference, especially if you desire to turn this CEU in or this webinar in for CEUs. You'll need that information. Both Beth and I are employees of LSVT Global and receive lecture honorarium, and we have a non-financial relationship, including a preference for LSVT LOUD and LSVT BIG as treatment techniques. So just a few logistics in case you are new to our webinars, and if you're not new to our webinars, we welcome you and thank you for joining us again for this one. Right now in GoToWebinar, everyone's microphones are muted so that there's no background noise from your different environments. However, at the end, we'll have some question and answer time. Usually it's a short time, maybe 5 or 10 minutes or so. And at that time, you can either type in your questions or you can raise your hand. There should be a little hand icon in your control panel, and you'll be able to ask your question out loud. And we'll go through more details about how to ask questions at the end of the webinar as well. At any time during the webinar, you can type your question into the chat or the question part of your control panel, and we'll save those questions for the end of the webinar. In terms of handouts, you should have been emailed a handout of today's slides. However, if you didn't receive that, they are in the handout section of your control panel. There should be a little triangle right beside handouts. If you click on that, you'll see 3 different handouts. One is the handout of today's slides so that you can download those or print those for safekeeping. And there are 2 other handouts that we'll be referring to in today's webinar. At the end of the webinar, you'll either be sent a link to complete the survey or there'll be a pop-up for you to complete the survey. And regardless of which method it comes, we do ask that you complete the survey after this webinar so that we can see how we did, and also there'll be an opportunity to ask questions and provide ideas for future webinars as well. A little bit of information in terms of continuing education units for all of our therapists that are joining us today. The LSVT Global webinars are not ASHA or state registered for CEUs for speech, physical, or occupational therapists, but they may be used for self-reported CEU credit as a non-registered or non-pre-approved CE activity. So if you're a therapist and you would like to report your activity, just email us at any time at webinars@lsvtglobal.com to request a certificate after you complete the entirety of this webinar. And the certificate will include your name, the date, and the duration of today's webinar. Please note that the licensing requirements for CEUs differ state by state. So the best thing to do is check with your state licensing board to determine if your state accepts non-ASHA registered or non-pre-approved CE activities. And lastly, attendance for the full hour is required to earn a certificate. If you are listening to this webinar in the future as an on-demand webinar, again, email webinars@lsvtglobal.com and we can indicate and go through the steps on how to get a certificate so that you can use it for self-reported CEU. In terms of the learning objectives, they are these for today. By the end of this webinar, we hope that you'll be able to outline the rationale for delivering LSVT BIG and LSVT LOUD according to a standardized research-based protocol, identify potential solutions to delivering the minimum frequency and session length for LSVT LOUD or LSVT BIG, determine whether LSVT LOUD can be delivered with the assistance of technology, LSVT Companion or LSVT eLoud, and Beth will be explaining what those are, and identify resources related to documentation and reimbursement, education of your therapy managers to support LSVT per protocol, and education of the PD community and physicians on the importance of the prescribed dosage. And lastly, summarize how an intensive standardized protocol can be personalized for each patient. So we welcome you to today's webinar. I'll be presenting this first part, and then I'll pass it over to Beth, who will present part of the middle, and then I'll join you again in the end. So if you're familiar with the LSVT protocols, you know that these are evidence-based therapy interventions designed to improve the communication, mobility, and function of people with Parkinson's disease and other movement disorders. So LSVT LOUD is a speech therapy, always delivered by LSVT LOUD certified speech language pathologists, and LSVT BIG is a physical and occupational therapy, always delivered by LSVT BIG certified physical therapists or occupational therapists or assistants in those professions as well, in collaboration with certified therapists. So the mode of the LSVT programs is intensive and high effort. And if you know anything about the LSVT protocols, this is probably not news to you that there's a minimum dosage for efficacy of the LSVT programs as established by research. So this dosage is 4 consecutive days of treatment for 4 weeks in a row. So they get a total of 16 one-hour sessions, and that does not include the evaluation. So that would be 17 if you wanted to include that. The sessions are hour-long sessions, and these are individualized therapies, not group therapies. The patients also have daily homework, practice, and daily carryover exercises all 30 days of the month. So it's really an intensive bolus of therapy for the patients. And as you probably know, these are individualized. So this is 1 month for LSVT LOUD or 1 month for LSVT BIG. Our goal is to make a lifelong habit of practice to really kickstart our patients, optimize their function, and then get them in the habit of practicing so that they can continue to exercise and maintain the gains that they work so hard for. So you might want to know, why is it so important to deliver LSVT BIG and LSVT LOUD per protocol? I think as therapists, we're very used to using evidence-informed therapy and using our clinical judgment and adjusting the dosage as we see fit. So let's talk about why these protocols are a little bit different and how we translate research into practice. So the LSVT protocols are supported by over 30 years of high-level peer-reviewed publications, and they include multiple randomized control trials, both for LSVT LOUD and LSVT BIG. So it's not just the principles that are supported in the literature of neuroplasticity and motor learning. There's actually tons of research done on this specific dosage and on these specific protocols. And so this gives us expected outcomes, and we expect to see significant improvements in communication and movement, and these are maintained for up to 2 years, depending on which research study that you are looking at. So these are well-supported principles of neuroplasticity in the protocols, but they're standardized and personalized, and we'll be learning more from Beth today about how that works. In terms of practice, patients receive the same treatment that is well established and results in lasting improvements. And we believe that because this research is so strong and so robust that we know it works when it's done correctly per protocol, we want our patients to get that gold standard treatment so that they really get the best results. And an analogy that we use sometimes is Starbucks. If you go get Starbucks in Denver or Starbucks in Philadelphia or Starbucks in Tokyo and order the same thing, it's really going to taste the same. You're going to, you have expected outcomes that will be delivered. And though each patient is very much different in terms of their goals, their stage of Parkinson's disease, their problems and issues, we can still have expectations of what they can achieve through these protocols. So it all sounds fine and dandy, but probably your burning question is, well, that's great, but can it really be done in real world settings? Or is this just a nice theoretical concept that no one actually applies? But our answer to you is yes, absolutely. And it works. And so 55,000 or more people have become certified and are currently actively certified in LSVT BIG and LSVT LOUD across the globe in 83 different countries. And we know that there are real world challenges to implementation, but that's why we're here. We are here to help you and provide solutions. And we have learned so much from our clinicians actually over the years on solutions that have helped their patients to be able to receive LSVT LOUD and LSVT BIG as well. So these are the categories of the common questions that we'll be reviewing in today's webinar. We'll be talking about how to deliver the dosage, some practicalities, how to feasibly do that. Beth will be talking to you about accessibility issues and standardization of protocols, as well as financial concerns. And we'll also be talking to you about how to educate physicians and managers and other decision makers regarding these treatment protocols. So let's kick it off and start by talking about probably our most common frequently asked question, which is how do you deliver this intensive frequent dosage of LSVT LOUD or LSVT BIG? So here's some of the common questions that we receive from clinicians and therapists like you on a regular basis. So first of all, will patients actually be able to attend therapy 4 times a week for 4 weeks? That seems like a big commitment for someone and might be too intensive for others. Second question, my clinic only allows us to see patients for 45-minute sessions. Can I do fewer repetitions of the daily exercises or shorten the hierarchy? A third common question, I work part-time, so fewer than 4 days a week, so I'll not be able to complete the full protocol. Will I just not be able to offer LSVT in my clinic? And all of these point to this common umbrella question of, can the LSVT treatments be completed in fewer sessions or shorter sessions? So let's go ahead and talk about each one of those individually and the rationale for why we would want to advocate for this standardized dosage. So really talking about the evidence is step one when we're talking about supporting this dosage with whether it's our supervisor, whether it's a patient, a physician, really anyone that's really asking you, why does it need to be 4 times a week for 4 weeks? And so we ask you to go back to that research. The research on the LSVT protocols includes multiple randomized control trials, and these all validate that this particular dosage for these treatments is effective. And we have no evidence to show that a lower dose can be just as effective. So we ask you, why risk it and lower the dosage if you have no idea if it will be effective for your patient? So one of the analogies that I think is actually very good, when you think of the fact that exercise is medicine, really it has potent effects on the symptom management in Parkinson's disease. Think about a pharmacist. Would a pharmacist alter the dosage of a medicine on his or her own when there's actual research on that drug, which has shown that that specific dosage is optimal for treatment of the symptoms? And of course, you would say, no, the pharmacist wouldn't do that. And for these particular protocols, we would say the same. Because of this really robust and strong research, take it seriously that it is like medicine for people with Parkinson's, but this dosage is very, very important in getting the best results. In addition, that dosage is important in neurorehabilitation. So think back on all of the literature that you've read on neuroplasticity and motor learning, and it all underscores and points to the need for training that is sufficiently intensive, frequent, and repetitive. And this is really reflected in the dosage of the LSVT protocols as well. So the same principles that make athletes excel at their sports apply to people who are fighting Parkinson's. So think about them in terms of, repetition of a baseball player practicing his swing or practicing his pitch. I mean, it's thousands and thousands of repetitions to not only gain skill, but to maintain their skill over time. They increase in complexity. If you think about a kid starting playing t-ball at 4 years old and progressing through high school baseball, that complexity of training increased over time. They practice intensively. The ones that really do the best in a sport or in a musical hobby or something like that are the ones that train intensively. And also the training is specific. So if a baseball player wants to improve in baseball, they practice baseball. And likewise, if we want our patients to improve in their voice and movement, we practice exercises and activities related to ADLs, communication, and movement. And lastly, you can look to in addition to behavioral changes, looking at neural changes have also been documented in the literature after LSVT LOUD. And these data document that intensive exercise, in this case voice mechanism, can have an impact on neural functioning. And one of the studies that you can look to is by Narayana et al. Published in 2010 that showed actual shifts in brain function and different areas of the brain activated after this 1-month treatment of LSVT LOUD. So exciting to think that we don't just think that neuroplasticity is happening, that we actually have some imaging data that supports it. So the question that you might ask is, will patients be able to come to treatment 4 times a week for 4 weeks? And what's interesting is once patients are educated and really see the potential that they have and the value, oftentimes they remark, wow, this went so fast. I can't believe that the month of therapy is done already. And oftentimes they want to keep going because it's been such a productive and positive month, and they've benefited from your intensive coaching as well. So short bursts of treatment are generally better than continuing low dosage of treatment. I think as a physical therapist, it's common practice to deliver traditional therapy twice a week for 8 weeks, which is 16 visits. But for some reason, when you shift it and say, well, let's, push all those visits in 1 month of 4 times a week for 4 weeks, oftentimes for us as therapists, it's a little startling at first, like, oh, wow, that seems like a lot. But it's the same visits all together, and our patients really benefit from that intensive burst of treatment in terms of their motor learning. And 16 hours is really not so long when you think of the big picture. Think of a person with Parkinson's going to live with this disease for many years and possibly even decades. And so it's just a little blip in time to really optimize their function and get them on the right track and then see them periodically over time. There's ways that you can improve access and improve the ease of giving this dosage. And Beth will be talking to you today about using the LSVT Companion and telepractice, both for LSVT LOUD and LSVT BIG. Another question you might have is, will patients be able to tolerate 4 times a week for 4 weeks? I know I've spoken with many therapists that work in home health environment, and they think, oh, there's no way. My patients are very advanced. They have lots of comorbidities. I don't think they could handle 1-hour sessions 4 times a week for 4 weeks. But I really want you to understand that these sessions are scaled in intensity within the session. So as a therapist, you'll be monitoring their respiration rate, probably their heart rate, giving them short rest breaks as needed, maybe doing fewer repetitions of things, but they can still tolerate the 60-minute sessions when you scale that intensity. And exercise really is fatiguing, and we have to acknowledge that with our patients, but what they don't see in week 1 is that their energy and their endurance will actually increase over time. And for those of you that are into fitness, of course, you know that from your own personal experience. People with advanced PD and those with cognitive impairments need even more repetition of practice for motor learning. So just think about how processing is slower, retention might be affected, procedural memory can be impaired, all of those neuropsychological deficits that are especially apparent in advanced Parkinson's disease require more repetition of practice for long-term success. So let's talk a little bit more about patient availability and scheduling tips. For patients that are, still working, is it possible to see them before or after working hours? Can you flex your schedule, or can they see someone that has hours that kind of match their availability, or could they even be seen during their lunch break? Be sure and look at their calendar and start LSVT when their schedule is open for 4 weeks. And it's not uncommon to really delay the start of LSVT Loud or LSVT Big for a few months. We've even had patients that says, well, I'm going to do, get on a home exercise program, go to the gym, maybe do some traditional therapy. And next May, when I retire, I'm going to come in and do LSVT then. So have that conversation about what will fit into their schedule and match your schedule as well. Certainly discuss transportation options. Oftentimes, if patients are given the option to set up a team of drivers, whether it be friends or family, and have time to do that, they can make it happen. So we say, all those people that reached out to you when you were diagnosed with Parkinson's and said, hey, if there's anything we can do to help, let me know. Well, now's the time to call them and say, hey, actually, I have something. Can you help give me a ride 1 day a week or whatever? Sometimes patients don't know about different transportation options available to them in the community, such as senior ride service, for example. So you might even tap into your social worker and see what kind of transportation options might be available in the community. You can also search for therapists in your area that do a mobile practice. So could they be seen in their home through a therapist that has a mobile practice, still bills that as outpatient therapy, but it will allow them to receive the treatment? So if there are other health issues, you might need to stabilize them or treat them prior to receiving LSVT Big. Sometimes we call that prehab. All right, another question. My clinic only allows us to see patients for 45-minute sessions. And I know this has become really, really common, especially in the United States. And we have therapists asking, can I do fewer repetitions of the daily exercises or shorten the hierarchy so that I can get everything done within that 45-minute session? So the answer is no, because clients will not be receiving the same evidence-based back treatment. You're essentially reducing the dosage by 25%. And so we say, let's look for some alternative solutions. First one is always education. Your supervisor or administrator might not really understand what the LSVT protocols are and all of the research that are supporting them and why they need to be delivered in these standardized dosages. And I know of many, many therapists who have sat down and provided education and been able to make a change in that way. Some solutions that you can offer them are to reserve 1 or 2 slots for LSVT patients per month, or reserve a consistent daily 1-hour slot in your schedule. So you can say, every day from 11 to noon is going to be my LSVT patient. You can run LSVT camps. So you can say, okay, the month of November, I'm going to really focus on LSVT patients. But advocate for yourself and your patients, because it oftentimes pays off. And even one of our own LSVT Big faculty faced this situation and was able to make a change with some education from to management. For LSVT Loud, you can utilize the LSVT Companion, which Beth will be talking about, for some of the at-home sessions for LSVT Loud. So educating administrators and directors is really essential. There's lots of ways that you can do it. Face-to-face meetings are always great to share your passion for helping people with PD and movement disorders and your vision of how your center could be really known as a center of excellence, not an official one, but it's just a center that's known for providing excellent care for people with Parkinson's that's evidence-based. For people that you're not in communication with on site, sending a flyer, a letter, emailing them, giving an in-service is another idea. Explaining the evidence is really key. Explain the rationale for the treatment and the dosage and your need to refer. If you are a certified clinician, or once you're a certified clinician, you'll have access to a prepared PowerPoint presentation with videos for the purpose of giving informational lectures. And remember, you can only market your LSVT program and provide LSVT LOUD or LSVT BIG and be listed on the directory if you're able to provide it per protocol. So it's important for management to know this as well. There are lots of different resources that you can use to educate your managers. This FAQ document for therapy managers is in the handout section of your control panel. You can feel free to download that, save that, share that if you'd like to. All of our references and research are listed on our blog, and we've listed the URL here. Our website and our blog in general have a lot of great information as well. The other question is, I work part-time, so fewer than 4 days a week, so I'm not able to complete the full protocol. Will I just not be able to offer LSVT in my clinic? And what we recommend in this situation is that you talk to another clinician about getting certified so that you can share that patient. Maybe one does twice a week, the other does twice a week, or whatever split works for your schedules. It could also be a sharing between a therapist and a therapy assistant. If you do share a patient, of course, clear communication and treatment notes communication is really, really important. And again, you can utilize the LSVT Companion for some of those at-home LSVT LOUD sessions. So now I'm going to turn the mic over to Beth, and she's going to be talking to you about access issues.
Great. Thank you so much, Laura, for that really nice introduction and overview of some of the issues and solutions that have come up. And I'll go ahead and start talking about some access issues or questions that we get, and then some solutions for those. So Laura was talking a little bit about transportation issues that might come up, and we certainly get these questions from either clinicians or patients who are concerned they won't be able to do the treatment because of issues that come up with transportation. So maybe the patient doesn't drive, they've never used a transportation service before, they're not aware that it's available, they can't get a ride 4 days per week, or they live a long distance from the facility. So next we'll see some solutions that are possibilities to help patients with this. And Laura talked a little bit about it, but some other ideas could also include a temporary stay with someone who's close to a clinic. So maybe they have a friend or a family member who lives by a clinic that does offer one of the LSVT programs, and maybe they can either stay there for the month or just the 4 days of treatment and they go back to their home on the weekends. Just kind of depends how far away it is or whatever scenario they worked out, but that could be something you can put into their mind to think about, and maybe there's someone that would be willing to host them while they're doing the treatment there. Laura also mentioned some in-home therapy practices. So it might be that someone who bills as an inpatient but comes to their house can offer the therapy in-home. Again, it might be a team of drivers, so maybe through a church group or a support group or any type of other social or volunteer group that they're in. Maybe they can have, Bob drives on Mondays, Sally drives on Tuesdays, and they work out a schedule so they don't feel like they're overburdening one person, but maybe it could be spread out, amongst a team of drivers who would be happy to help them with it. And then also advocating for clinicians to get trained in rural areas. And maybe this is yourself as a clinician in the audience. You think, well, I only see one person with Parkinson's all year. It wouldn't make sense for me to get trained. But know that LSVT LOUD and LSVT BIG can both be applied to populations outside of Parkinson's as well. And that can be something that you can educate administrators, managers on, and they may be willing to assist with the cost of the course so that you can become trained and you could bring more patients into your clinic, both with Parkinson's and then other disorders that it could be applied to as well. And then making sure you're educating patients on the importance of intensive dosage. So just as Laura mentioned, sometimes they're hesitant up front because it seems like a big commitment, but then when they really sit down and think about it, you're making a huge impact in their life, and it's just 1 month over time. And they again can potentially live for many more years or decades, and having just that 1 month of treatment, 16 hours in 1 month, is not that big of a commitment when they think about the big picture. So really just educating them on the importance of the dosage, the research that's out there to support it, and then the types of outcomes that they can expect from that intensive month. Some other accessibility solutions could be to utilize technology, so both telepractice for LSVT BIG and LSVT LOUD, and the LSVT Companion, which can be used for LSVT LOUD. So with telepractice, so we have research to support both LSVT LOUD and LSVT BIG delivered by telepractice. So we're seeing the same types of outcomes when LSVT programs are delivered over an online platform versus when they're delivered in person. And so we have some research studies here on the slide for you. And one, kind of silver lining of COVID is that it has helped make telepractice more acceptable as a method of delivery. So people are getting more comfortable using technology. So maybe patients who might have been more hesitant with it before, maybe they've been Zooming, for the past year with their grandkids or other family members and friends, and maybe they're more comfortable with it. And then just in general, the field of medicine and rehab is becoming more accepting of this as a mode of delivery. So it's more accessible to you both as the clinician and the patient. So I'll specifically also talk about the LSVT Companion, and there's both a client edition and a clinician edition. And this is a software system that can be used in conjunction with LSVT LOUD therapy. So with the LSVT Companion, there's a few key features that can really help make it usable and for at-home treatment sessions. So what you see on the screen here, the bottom left, is a picture of what a patient would see when they're doing the exercises, and it provides them real-time audio and visual feedback based on goals set by a clinician. So a clinician would go in and set, the target loudness level, the target duration, and the LSVT Companion would prompt the client to, say your loud ah, ready, start. And they do their loud ah, and they get the feedback on the screen. And then also at the end of every session, they'll have a spreadsheet with the calibrated sound pressure level, frequency, and duration that's been automatically calculated and documented for their either treatment or home practice. And so that can be shared with the therapist. They can email it as an attachment so the therapist can keep up with and monitor how they're doing at home, whether it's for treatment sessions at home or continued homework practice after treatment has concluded or during the month of treatment. So next I'll share the research study that's been done. And so this was a research study conducted where 7 of the 16 LSVT sessions were done at home independently on the LSVT Companion, and 9 of the sessions were done in person in the clinic with an LSVT LOUD therapist. And so what we're seeing, we have decibels of sound pressure level here on your y-axis, and then we have a variety of reading and conversational tasks on your x-axis there. And then we have pre-treatment, post-treatment. So pre-treatment in purple, post-treatment in that pinkish color, and yellow is 6-month follow-up. And what we're seeing are some nice improvements in decibels of sound pressure level or vocal loudness from pre to post that are maintained out to 6 months of follow-up. So that's exciting because it's consistent with the changes that we're seeing when all 16 sessions are done in person. So this lets us know that the LSVT Companion can be used as a mode of delivery for some of the treatment sessions to be conducted at home. So if you're interested in learning more about that method, there's a research article that was written up about it. It won an award at ASHA, which is the kind of the governing body of speech language pathologists. And so it's very exciting because it was great research that was done and really nice findings to show, if individuals are having trouble getting to the clinic 16 sessions in a month, this is another possible solution for them to still be able to get that efficacious dosage for the full 16 sessions. So some potential uses of the LSVT Companion, as I mentioned, some of the sessions can be done at home, some independent treatment sessions. Some clients like to use it for homework practice. So during the month of treatment, they would just use the LSVT Companion kind of as an adjunct, and it helps them get through their practice every day. And then some patients like to continue using it after LSVT LOUD has concluded, because after treatment, we still want patients to be practicing every single day. And so this is a good method for them to help keep them on track. They still get the spreadsheet every day after their practice. Their therapist can also check in with them and have them email those results, down the road to see if they're still matching up to the same discharge scores. So it can really help everyone stay on the same page with how the patient is doing. So it's an exciting system that's been developed that can really assist with either treatment or homework practice. And for those interested, so for the speech therapists in the audience, once you're LSVT LOUD certified, we also offer LSVT eLOUD training, so at no additional cost. So if you're interested in becoming an LSVT eLOUD provider, there's a free webinar that we've done. It's a 2-hour webinar that just goes through the research, some of the regulations and logistics, really gives you the practical considerations for how to deliver LSVT LOUD via telepractice. So that's an exciting course that's available so that you're confident diving into the telepractice world, and that you have that support to know how to do it efficiently and optimally, I should say. So our next section that we'll cover are practicalities for practice settings. So there's a couple kind of overarching questions that we may get from clinicians in various settings. It might be that we don't see patients for 4 weeks in my setting, or I'm not allowed to see patients 4 times per week in my practice setting. So it might be, you just think we can't offer LSVT in my clinic because of these barriers to access. So we've broken up some solutions in various settings on the next few slides here, so you can see which one might be applicable to you. And I know we had a question come in earlier about what to do in an inpatient setting. So this kind of gives you an overview of steps you might consider, or kind of options to consider in the inpatient setting. So it might be that you're screening candidates in inpatient to see if they might be good candidates for LSVT LOUD or LSVT BIG. You might be educating patients there about what these treatment options are. So even if they don't stay in inpatient long enough to receive LSVT, or they're not ready yet, they're at least educated about it. And now, when they're discharged, they can seek out an outpatient clinic or a therapist to deliver the treatment afterwards. You can also do stimulability testing. So with stimulability testing, you're doing some of the exercises with them with the same intensity, same effort as if you're doing a treatment session, to again see if it might be applicable to them, if they would be a good candidate for either LSVT LOUD or LSVT BIG, and then starting LSVT when they're able. It might be that you need to focus on other aspects or other issues that are going on before you can start LSVT, so you might not be able to start it right away, but it's certainly something that you could start, and then you can assist with discharge planning and therapy referral for another clinician to pick up in the next setting that they're going into. So if they're going to go to the outpatient setting next, maybe you've done a week of treatment in your inpatient setting, and you have this connection to a clinician in an outpatient setting, and you're able to discharge them, and they pick up right at the next week, and they're able to go through the full 4-week protocol. So that's some options for therapists that are working in the inpatient setting. Another setting we get questions on is the home health setting. So we do know and recognize that patients in the home health setting are often ones who may have cognitive challenges. They might have more advanced Parkinson's or other comorbidities, but know that they can still make progress. So they can still make progress across those 4 weeks to really have some functional outcomes that that really make a difference in their quality of life. So if you work in home health, it might be that you're doing, we'd recommend trying stimulability testing again to see if they'd be a good candidate, and then do a trial week of the treatment to see if they're making good progress. If you like what you see in that week, then we say continue for your full 4 weeks of treatment. You might be bridging treatment across different care settings. Again, just like you may have in the inpatient, if they transfer to another setting, the same thing may happen with home health, but you can get started and then transfer the patient to another setting. So we have this point about teamwork. So a PT and OT partnership can be really beneficial for patients. Likely if they're in the home health setting, they're receiving both PT and OT. So it might be that the PT sees them for half the time, the OT sees them for half the time, still getting the full 16 sessions. It's just divided between the PTs and the OTs. And so that might be more feasible for some of the patients that you're seeing. Laura also mentioned the notion about prehabbing. And so with that, you may need to treat other conditions first, or just to kind of prime them for the LSVT treatments, and then transfer them to outpatient therapy where they could begin the treatment there. So it might be you're just kind of getting them ready, and then you transfer them to someone else who begins the 4 full weeks of the protocol at the next setting. If you're a therapist who works in a long-term care setting, In those types of settings, it is important that you're working with staff members to educate them on how you want the patient to be cued in their care. So, depending on where you are in treatment and where the patient is, we wouldn't expect them to just, the first week of treatment have this loud voice in all settings or these bigger movements in everything they do. So it's important to help the staff know when would be appropriate times to cue for those bigger movements or that louder voice. And they can be a huge help and huge support to the patients that are in these settings. In terms of dosage, you may need longer than 4 weeks or 4 days of therapy per week. We do kind of have a caveat with that. When you go through the training course, you would learn that we never want to take in a patient and think, oh, I'm going to do 6 weeks with them. We wouldn't ever want to get to that until we've at least tried 2 weeks of treatment with them. And then we see, oh, if I just had another week, I think I could really get them to the end. Because we never want to go in with that bias of, oh, this patient is just too frail. There's no way that I'm going to get there. Because then you might not go, as intensively or as high effort in your treatment sessions. But it may be the case that for some of these patients who are more advanced, that if you just had an extra, week of therapy, you can really get them to that outcome that you've been working on. For homework, so we want to make sure that we find someone who can assist or supervise their homework sessions. So maybe that's a staff member who even just reminds them every day, okay, it's time to do your homework, or it's someone that sits there with them through the sessions. A homework helper video, so we have those for both LSVT LOUD and LSVT BIG. They're either DVDs or digital formats. And so those can also just be played and a patient can follow along with the video. And so that might be a tool that could be used in this type of setting to make sure that they're still doing their homework outside of treatment. So in this type of setting, teamwork is essential. We want to make sure that the staff are aware of what goes on with the protocol and that they're also aware of how they can help. And this next slide talks about bridging LSVT across practice settings. We've touched on it a little bit in each of these different categories, but just making sure that you know that you can start LSVT in your setting and then transfer the client to another setting to complete the protocol. You can also do the reverse and receive patients who have started LSVT in a different setting, and then they come to you and you complete it. So the best practice with this is a phone call to really talk through where the patient is, and a clear discharge summary. So we want to make sure that we know the goals, how the patient's doing so far, and really any nuances with treatment. So for example, with LSVT LOUD, we'd want to know, were there any techniques you were using to really get the best voice of the day? It might be doing, ha instead of ah. Just different techniques that the therapist has been doing so that it's as smooth of a transfer as possible. And then again, just making sure those notes are really clear so they can pick up without any hiccups in the middle. So you can certainly bridge across the different practice settings so that the patient is still getting the 4 weeks of treatment and getting that full protocol. We've also had clinicians who might say, well, I'm not allowed to see patients 4 times per week in my setting. And so to that, we'll say, well, in most cases, yes, you can. But the question is how? And a big part of this is advocating for evidence-based therapy. And Laura talked about this a little bit previously. I think slides 22 and 23 are really helpful for some of the resources that are out there. It may just be that, administrators or directors at your facility don't know much about the evidence, but with the treatment that you're trying to provide, and they don't know why it has to be done 4 days per week. And a lot of times if they're just educated on the evidence base for it, then they'll come around and say, okay, well, let's see how we can make this happen. So it's important to know the regulations of the insurance provider and your organization. So oftentimes it's not the insurance provider that's limiting the number of sessions that are to occur, but something in the organization has caused them to say that they can't see patients 4 times per week. So again, it really goes back to that education, being an advocate for your patients and yourself to show that you can deliver this treatment and this is why it needs to be done that way. And then you can try some of those other solutions that Laura mentioned to try to help you get those slots available for your LSVT patients. So we say you may have to fight for it through that education and awareness, but know that we're here to help you with the resources. We want you to be able to deliver it. And so we have resources available to educate those in your organization that need to be educated about it so that you can deliver it for the full protocol. So the next section we'll talk about is standardization and what it does not mean. So we know we've been talking a lot about, you have to deliver the protocol this way in order for it to be LSVT big or LSVT loud. So then some questions that we get are, well, how can I personalize treatment if I need to follow the same protocol for every patient? Or isn't my patient going to get bored with these repetitions of all the exercises? Or you might be someone who really likes to utilize your clinical skills and you think, well, I'm going to be really bored when I'm doing the sessions. I want to make sure that I'm exercising my clinical skills. So we have some responses and solutions to those questions. So first, no two patients are the same. So yes, the protocols are standardized, and that's because they're supported by those years of research, and it does incorporate the principles of neuroplasticity and motor learning. So we do need that repetition. We do need that intensity. We do need that high effort because we want to get the patient really working hard every session. But within this structured protocol, there's customization of the treatment activities so you can personalize and tailor the goals to each patient that you're seeing. And practice makes better, but practice never ends. So people with Parkinson's need even more repetition, as the non-motor symptoms in Parkinson's can affect things like learning, attention, procedural memory, and other aspects. And so, yes, we do have multiple repetitions of the exercises, but that's necessary in order to make a difference for your patients. And these repetitions don't have to be boring. So you can certainly add in challenges. So for example, with LSVT loud, it might be, they're going to do repetitions of an ah exercise. And so you always want that healthy vocal quality, and you're always trying to see, how long can they keep it. But it might be if there's someone who likes math, you might say, okay, I'm going to give you a math problem. I want you to solve this math problem while I do an ah, or while you do your ah, and at the end of the ah, I want you to tell me the answer. So you might say, okay, what's 23 plus 13? And they're saying, ah, and they're thinking through the math problem. And then they say it's 36 at the end. And so now were they able to maintain their loudness while they're also doing, a dual task in their head. And so there's ways, and we talk about this a lot in the course and through other webinars, on how can you keep it challenging for the patient while they're doing these multiple repetitions. So we also say that as a therapist, you're going to put your critical thinking on as only you, a trained therapist, can. So you're constantly looking to see, is their amplitude of voice and movement optimized? What can be bigger or what can be louder? How is the quality of their voice or movement? And how can you make it more challenging over time? How will you adapt if they have comorbidities or unique challenges, if they're more advanced, for example? And then how can you link the exercises to function in a way that resonates with the patient? And how can you make their practice as real world as possible? So again, these are tools that you have as a trained therapist, both in your profession already, and then when you go through further training as an LSVT loud or LSVT big therapist. So these are critical thinking skills that only you can do and see and work on throughout the treatment sessions. So some solutions to help you effectively deliver the standardized protocol. So again, the question might come up, well, how can I personalize it if I have to follow this same protocol? So one really big key component for both treatments is saliency is a key principle of neuroplasticity. So it's so important to personalize your materials for each patient. And the goals and activities that you do with your patients are based on your patient's needs and desires. So on the speech side, an example of an early Parkinson's goal, so for someone who's earlier in the course of their disease, the patient will be able to effectively project voice during business meetings and phone calls. So it might be that they're still actively working and they use their voice a lot at work, and this would be a really functional goal for them. For those with advanced Parkinson's, a goal might be the patient will be able to communicate needs over the telephone in case of an emergency. So again, very functional for this patient. So you can imagine during the course of treatment that the activities that you're doing with each of these patients is going to be very different while you're still doing the same amount of repetitions, the same length of time, the same intensity, the same high effort. It's going to look very different for each patient. So there was an article in the ASHA Leader, I think this was in 2018, a few years ago, 2018, right on the slide. So it talks about tossing the workbooks because, we don't want patients to come in and do these repetitions where they're just saying word lists, salt and pepper, shoes and socks. It's not motivating, it's not salient to them. So it's important for both LSVT loud to choose readings that are salient, conversation that's salient, and for big, so activities and movements that are salient to this patient's everyday life to really make that difference to get the outcomes that we can expect after the end of one of the LSVT protocols. So some other questions again that come up. I worry that my patient will get bored with the repetition. So we talked a little bit about that. Personalize the materials and the tasks. So you're not repeating, in LSVT LOUD, you're not repeating the same readings every day. What I do like to do when a patient does have an interest, so maybe it's golf, for example, I'll find readings related to golf for, the 4 weeks of treatment, and I'll keep those in a binder. And if I have another patient who likes golf, I'll pull out some of those and see which ones could apply to them. And then you're working on functional skills that actually matter to the patient. So again, with both loud and big, making sure that we're going through and seeing what the patient needs to work on, what they want to be accomplishing, and you're working on those skills. And as I mentioned, you can add challenges as they progress. You can add motor and cognitive dual tasking during the daily exercises, during the hierarchy practice, which are the 2 components of the LSVT protocols. So you can always add challenges to make it more difficult. Once they've optimized their movement or their voice at one level, how can you continue to challenge them? Can they keep that movement, while they're also talking on the phone to their grandkids? So those are things that are really functional and important to make sure that it transfers outside of therapy. So we also say be engaging, so patients feed off your energy. So of course a patient's going to be bored, even if they have salient materials. If you go in and you say, okay, say ah, good, do it again, move like this, do it again. And if you're not engaging, then they're certainly going to feed off that energy. So you as a clinician also want to, what we say, like modulate your modeling. So be as energetic and engaging as you can, and the patient will feed off that energy. Again, you might be concerned that you can't use your clinical skills. So the focus is simple for your patient. We only want them thinking about loud or big. But as a clinician, you're constantly assessing, redirecting, modeling, shaping, calibrating in order to find that best voice and movement for each patient on every day. So you're always constantly thinking, how can I push the patient further? And some financial concerns that may come up. So you may be thinking, okay, this all sounds great. I'm going to educate, my administrators. I'm going to get LSVT programs in my clinic. But then you're like, well, wait, is it reimbursable? And so again, our big answer here is yes. So what are some considerations? So your practice setting, your place within a continuum of care, if you're acute, outpatient, home health, your work leadership and culture, but really the key here is the strength of your documentation. And we say with that, everything else can kind of fall into place. So we have some resources listed here. So when you are an LSVT certified clinician, you'll have access to a clinician account, and it has resources for all kinds of different reports. There's an appeal letter, fact sheets, reference list. You'll have access to a lot of webinars on documentation and reimbursement. You'll have access to an expert, either LSVT LOUD or LSVT BIG, that can help you with any reimbursement or documentation concerns. But just knowing that we've had great success with reimbursement across many different types of care settings, and these resources are available to you to make sure that you can also have success. So some more specific ideas with reimbursement. So we say always, be in touch and working with your business office. It might be that some insurances are requiring that the treatment sessions are pre-authorized. So making sure that you're checking in with the business office and that they're contacting the insurance when needed. Assist with resources, researches as needed to support authorization. If the patient does have a copay, are there assistance services available? So maybe sliding scales depending on income, certain discounts you can offer, or payment plans. If a patient does not have insurance, think about what is your self-pay rate? Is that matching other providers in your area? You can also discuss the option as a full rate. So maybe you have 17 sessions times, whatever your per visit rate is, and then they'll see what the real value is to them. Maybe this could be a gift. So maybe they ask for this for their birthday or for Christmas. If there is a hard visit limit, so you could complete the remaining visits under self-pay, and you would want to prearrange this so there's no disruption in care. We also say to beware of myths and mistruths. So make sure that you're really getting the facts. So does Medicare have a cap or threshold that we cannot exceed? So Medicare's guidelines indicate that you can continue to treat a patient if it continues to be skilled and is medically necessary with reasonable expectation of progress. So you can read about those on through the links here, but just knowing, again, this comes down to your documentation as a skilled professional and showing that it's medically necessary. If insurance won't authorize additional visits, sometimes that's true, but more often it just requires an appeal. And so we have sample appeal level letters available to our clinicians. And then maybe you just need to reach out to the clinical reviewers and provide education and research to them. Again, you can show them the fact sheets, some of the randomized control trials to show them why you need those additional visits and why it's medically necessary. And just a quick review for Medicare for outpatient services. So right now there are annual thresholds, but you are permitted to exceed them when you append the claims with a KX modifier. So there's just information on the slide here. If you're working in outpatient services, you're probably aware of this. But if that's a concern, just knowing that when you add that KX modifier, you are allowed to go above the annual threshold. And then a few other resources for you. So there's a home health FAQ sheet that we have in the handouts tab on your webinar control panel. There's the patient-driven groupings model. So we have some therapy myths there if that applies to you. And then busting Medicare myths. So some helpful links to take a look at to make sure that you're well educated.
I lost your audio, Beth. Are you still able to hear me? Just 1 minute. Just want to make sure that you all can hear the audio.
Yes, I can hear you.
Okay, thanks for confirming. All right, well, let's wrap up this webinar by talking about informing the informer. So educating people that make decisions and need to know about the LSVT protocols. And then Beth and I can stay on for a few minutes if needed to answer your questions as well. And if you have to jump off at the top of the hour, feel free to do so. So oftentimes you might get questions from neurologists and primary care physicians, and we get questions also from clinicians about how can I inform referring providers and educate them about the LSVT program. So one of the best places to start, of course, is the research, and you can find that all on our blog in the research section. If you're hearing some questions or misconceptions, it's important to be able to clarify those. So clarifying that the treatments are not just exercise, that these are actually skilled therapy and include very personalized communication, ADL, and mobility training. Sometimes physicians think that LSVT LOUD or LSVT BIG make patients shout or talk too loud or move too big. So again, it's important to clarify that no, the end result is a normal amplitude in relation to their voice and movement. Will insurance pay for treatment? Yes, it will pay for treatment. And in this regional area, we tend to refer to XYZ treatment or a community-based exercise class. And I would say, well, that is, great that exercise really is important for people with Parkinson's disease, but this is a specific evidence-based protocol, therapy protocol for people with PD. So again, education is the answer. And we provide a bunch of information and resources to help you. If you are certified, you'll have access to our fact sheets and an informational lecture and videos in your clinician account. So if you can give them an in-service, that's a wonderful thing to be able to do. On the simple end of the spectrum are some brochures. You can either make your own or use the brochures that you can find in the store. And one of the best things that you can do is write a very simple, to the point letter to physicians and support groups to say, hey, I'm LSVT certified. This is in a nutshell what it is. I'd love to be able to talk to you more about it. And of course, there's instances where you can't offer LSVT per protocol, or maybe it's not appropriate in that certain instance. And so we always say, what are the other evidence-based treatment options that you can provide? And really, that's the heart of the matter, is providing evidence-based treatment. And you can do that by looking at the evidence-based maps. And we've listed them here for you from ASHA. They have an evidence maps homepage. They have one specifically on Parkinson's disease, speech and voice. For OTs, there's a great website called otseeker.com, and for PTs, there's a database called Pedro. That's really quite wonderful. And then, is there a future possibility of offering LSVT to the patient when timing is better or when your patient is ready? I think of an example that my colleague shared with me of a woman who started LSVT and just really wasn't able to keep up on her homework. So after the first week, the patient said, you know, I should have thought about this more. This is the very busiest time of the year in terms of my work, everything that's going on. I love this treatment, but can we put a pause on it and do it in April when I have more time? And because of that simple conversation, they were able to, you know, reschedule it for April. The patient was able to, you know, dedicate her heart, mind, and soul to it and end up having an awesome outcome. So good news for you as therapists is that once you've created a successful pathway and proactively found some solutions, it is easily replicated. Hopefully you've seen that there's a library of resources for people with PD, and your library of resources will continue to grow so that you can go to that proverbial tree and pick the fruit that suits each situation. And because the treatment has known really robust outcomes, you know what? Your patients return and they tell their friends that, wow, this was an intensive month of therapy, but it really worked. And their friends are going to be able to see that in terms of their voice and movement as well. So, few summary points. Identifying those potential barriers to delivery of LSVT per protocol is the first step in proactively identifying solutions. So discover what those barriers are, really dig in and communicate with your patient. A wide variety of solutions exist to enable patients and clinicians in many situations and practice settings to be able to deliver it per protocol. But education, advocacy, communication, and planning are essential, and they really do result in successful implementation of LSVT LOUD and LSVT BIG. And that's what we really hope to share with you during this webinar, that it is possible, and we feel that you feel empowered and that you have some ideas of different situations that you might be facing in your practice setting or with your patients, so that you can hopefully someday provide these treatments yourself. We want to invite you to join us next week. We have a couple of bonus webinars on Lewy body dementia. The first one is for therapists. It's next Tuesday from 7 to 9 Eastern. This is a free webinar. It's for all therapy professionals. You don't have to be LSVT certified. And it's going to be a great webinar with a movement disorder specialist and 3 therapists, PTOT and speech, all talking about Lewy body dementia. You can find this on our blog in the events page to register. And then we have one for people living with Lewy body dementia, their friends and family. That one will be next Wednesday, so a week from today, from 2 to 3 Eastern. So please invite people that you know that might be interested in that webinar. Again, that's found in the events page of our blog. Next month, our public webinar in November is going to be on advanced Parkinson's disease. It's called It's Never Too Late, How LSVT LOUD and LSVT BIG can improve function and quality of life in advanced Parkinson's disease. And that one will be Wednesday, November 10th from 2 to 3 p.m. Eastern. Same thing, go to our blog, find the events section, and scroll down. So Beth and I will stay on for a few minutes. If you do have questions, you can type your questions into the control panel. If your question is a little bit more complex or you're not a fan of typing like I am, you can raise your hand and we'll unmute your microphone so that you can ask it out loud. Or if you're out of time and need to go or think of a question later, please do email us at info@lsvtglobal.com. And then lastly, if you ever have any other questions, same thing, email us, go to our website. There's a ton of information on there. Remember to complete the survey that will display on your screen after you exit the webinar. And it's a very short survey. It should take you 5 minutes or less to complete. All right, so just going to our questions here, Beth, and I think there was that one that came in, and I think that you addressed it as you went through, and I'm not seeing any other questions that are coming in right now. Beth, any final words while we're waiting for a last question?
So any final words? So let's think. I'm trying to think. Last night we did a webinar focused specifically on LSVT LOUD, and I'm trying to think because there were some good questions that came through for that one. They were, they had to do with reimbursement, which I think we covered here. Oh, you know what they were maintenance. So there were questions about maintenance and if your setting allows for you to continue to see the patient, are you able to continue to see the patient once the 4 weeks of treatment have concluded? And so that was really interesting. So we had a clinician on there from Australia, and so she's continuing to see the patient once a week. And so this is a speech therapist. So she's working not only, she's doing some of the LSVT loud exercises, but then she's also bringing in, goals for cognition and language. And so she's continuing to work on that. So it's been a really nice model for her. And it works there. So there was a question about, would Medicare in the United States pay for something like that here? And so, the answer, I guess this is kind of a hard question to bring up because the answer was, it might depend. A lot of times once treatment has concluded, there's possibilities to do maintenance groups. There's Loud for Life or Big for Life, where they can continue to practice their exercises in a group setting, but those would be cash-based, and they wouldn't be, billed to insurance. So if you're, because at discharge, then you would expect to have met their goals. And so then you wouldn't be continuing to work on those. But if you're working on other goals, then you can certainly incorporate some of the LSVT loud exercises with some of those other goals. For example, that cognition or language, if you're, working on speech therapy goals. So that was interesting. It was a nice discussion about a maintenance. And then the question came up also, once you finish the 16 sessions, would a patient need to come back in a couple years and get the full protocol again? And so when we train clinicians in the workshops, we talk about, it's a model of care that goes on forever. Just like you would see the dentist every 6 months, you would also want to be checking in with your patients every 6 months, and some patients even sooner. And so it might be that they come in for tune-up sessions. So maybe they just come in for 2 to 6 sessions. You get them back to where they were at discharge, and then you let them go again, and then you just continue to check in with them. And we do say that it's very rare at the end of 16 sessions of treatment that you would have to bring in a patient again for the full protocol, unless they did not receive the protocol, the correct protocol the first time. But it is something that we do want to keep up with them. We want to keep following up with them to make sure that they're continuing to do practice every day. And again, if needed, they can certainly come back in and do some tune-up sessions. Again, rare that they'd have to do all 16. On average, we say it's about 2 to 6 visits. But just to give an idea, once treatment has concluded, then what does it look like after that?
Mm-hmm. Yeah, I think those are great things to bring up, Beth. Thank you. And, I would say that if you're not a certified clinician and are thinking about it and planning on getting certified someday, just know that, like Beth said, there's tons of support for you beyond what we listed, even in the webinar today. We have Zoom office hours every week that if you have a particular question, you can jump on Zoom every Tuesday or Wednesday and chat with our faculty. We have dedicated expert faculty that help with clinical questions all the time. And we have Facebook groups. I know the LSVT Big one is about 2,500 people or a bit more. Really active community of clinicians sharing ideas with clinicians on really how to make it work and just other treatment ideas and interesting clinical patient scenarios. So just know that you're not alone and it is possible. And I think that's our bottom line for today's webinar is we hope that that message came through loud and clear. So we're out of time. In fact, we're a few minutes past time. Thanks for staying on. I don't see any more questions that came through today. So I thank you all for your time, and hopefully we'll see you in our next webinar.
Thank you.